Hello, everyone. Nice to see you again. In my previous video about CT scan, we talked about how to read a normal head CT scan. To go into this, how to read abnormal head CT, you need to go back to my previous presentation and see, how to read a normal CT scan. Only then you'll understand a pathological CT scan. So having said that, again, reading CT scan is important for all of us medical students, medical doctors, irrespective of whatever specialty they are in, because it has become such a common, investigation that you can interpret your own CT scan to some extent, although you will need, detailed representation or reporting from the radiologist, but at least you should be able to immediately know what is happening there, whether you are in ICU setup, in emergency setup. You need to, be able to recognize few of the important CT findings. So today I'm going to, briefly show you major common pathology and how it looks in CT scan. So I start with CT of the head on injury patient, and this is my first slide where you can see that the patient has got a disruption of the bone here, and then there's a trauma to the brain parenchyma as well. Here you can see in detail that there is a fracture of the bone and then the parenchymal, but then you do not appreciate the bony structures very well. So for this, you need to have a bone window. And you should also notice here that there is a pneumocephalus. There's air inside the brain, which means that this is a penetrating injury, and it has gone through and through into the dura and into the parenchyma. So this is a compound, sort of situation, compound depressed fracture, and these patients need surgical correction and repair of the wound. So in order to see the bony structures better, you should ask for a bone window like this, where you can see the bony structures very well. This person has a impact on two places here and also in the frontal, occipital, and frontal area. In the skull base also, you can very nicely appreciate the fractures in the skull base. So bone window is pretty important when you ask for a head injury patient CT. Now, another common thing that you see is bioconcave sort of picture. This is an epidural hematoma, and so the hematoma is outside the dura mater, and the dura is being peeled away from the inner aspect of the skull. So you see it like this, a bioconvex sort of thing, and then these are very good for surgery. And subdural hematoma, again, it's a one side is convex, but another side is concave, and this has followed the contour of the brain. So by this look, then you should be able to differentiate between epidural and subdural, acute subdural hematoma. And here, how you calculate the shift. So this is how you calculate the shift. How much of the shift has occurred from the midline. You actually look at the septum pellucidum and look at the shift of the septum pellucidum from the midline. Many times you see injury on the scalp injury on one side, and then the brain injury on perpendicular to where the patient had his injury. So this is called counter-coup injury. So a coup injury is where you have the injury itself, but counter-coup is when the brain shakes within the calvarium. Then you can, because of the difference in the density of the skull and the brain moves in a different velocity, and then actually the brain goes and hits the inner side of the skull, and then you see something like this, the counter-coup injury. Again here, many times you see something like this when the patient fall down, hit his back of his head in the bathroom or something, then his brain is shaken, and then they have bifrontal contusion, again, or Coup-Countercoup injury. So this is the direction of the force that took from here to here to have that injury there. Sometimes the CT may look pretty silent, like in this case of a severe high-velocity head injury patients, but you can see sometimes a petechial small hemorrhage like this all over the brain, and also between the gray and the white matter, especially on the vortex area like this, which is also called a gliding injury. The gray matter glides over the white matter, and then these are diffuse axonal injuries. These patients, although the CT looks pretty, benign, the patients do not wake up well, and many of them may become even vegetative. So, in a high velocity injury, even if the CT scan looks pretty normal, the patient may do pretty bad in prognosis. Another case of, Coup-Countercoup injury here. There's a bitemporal. You commonly see, just like bifrontal you also see bitemporal, where the brain has shaken and then hit the inner wall of the calvaria. And this is a bullet injury where the entry point is somewhere around here, and then it has blasted and has scattered. The bony chips are there, the small blood fragments are there, and that's the exit wound. So, and a lot of damage has occurred in this area because of the velocity of the injury, the vacuum created. So, although the opening looks so small in both sides, they will have a profound brain damage. And this is some kind of penetrating injury with a knife. And you can see that there is a hematoma all the way on the track and also in the ventricular system. Now, another commonly used CT scan is used in stroke patients, because you can get a CT scan pretty fast. Most of the stroke patients are either restless or cannot be left in the MRI shoot for 30 minutes or 40 minutes or so. So initially we always do a CT scan to differentiate whether it's a bleeding or an infarction. Here you can see a basal ganglia bleed on both of these cuts, and the internal capsule is actually pushed to the medial side. This is outside the internal capsule, and you can calculate the amount of the hematoma by X, Y, and Z, and then dividing that by 2, then you get the volume in ml, and then you can decide whether you need to operate on him or go by non-surgical management. So again, this is a thalamic bleed. Here the thalamus has bled, and the internal capsule is actually outside the bleeding, and but then there is no ventricular spillage here. But here the thalamus has bled, and the hematoma has split over into the ventricular system. And as you can see, the ventricular system is enlarged here, and both of the Monroe is blocked by the hematoma. So there's a hydrocephalus thalamic bleed with intraventricular spillage. And in brainstem bleed, you can see that the bleeding can happen in medulla like this, which is pretty profound bleeding, although the amount is so small. In the pons like this, horizontally oriented bleeding, and also in cerebral peduncle, where you can see a bleeding like this. And all of these are pretty small bleeds, but the patients are profoundly ill, and they need a lot of treatment in order to bring them back to, most of the time they don't become normal, but then to bring them back to as normal as possible. And you can also have purely intraventricular hemorrhage like this, where you can see that the cast is here in the fourth ventricle, in the third ventricle, in the lateral ventricle. And this slit here is the aqueduct, where you can see the bleed there as well. And here is in the lateral ventricle, third ventricle, and also in the lateral ventricle on both sides. So this is purely an intraventricular bleeding. But you can have a cerebral bleed just like that, the parenchymal bleed on cerebellum, and without ventricular spillage, or with a ventricular spillage into the fourth ventricle. And in this case, the blood is small, but then it has gone into the fourth ventricle. And you can see that already the patient is having a hydrocephalus, a little bit of enlarged temporal horn on right side. And these are, lobar intraparenchymal hemorrhages, which is not, most of the time, you don't see it in hypertensive, just like basal ganglia bleed, which is most of the time associated with hypertension. These bleeds are either, some kind of vascular malformation, cavernoma, AVM, or, in the old age, some kind of, vasculitis or, demyelinating degenerative arterial diseases leading to bleeding. So most of the time when you see something like this, then you order for angiography as well. And the bleeding can happen inside the brain, but not actually in the parenchyma, but on the surface of the brain, just like in this perimesencephalic bleed with a little bit of hydrocephalus, pretty tight brain, and anterior to the pons, and in the cerebral peduncle there is some blood is seen. But this is in these cases, this is a subarachnoid hemorrhage. Although we call it a perimesencephalic bleed, we need to do a angiography, either a CT angiography, conventional angiography, or MR angiography. And if it is negative, then you just treat the bleeding only. If there's some pathology there, then you need to deal with the bleeding point as well. Now, coming back to subarachnoid hemorrhage, many times you miss subarachnoid hemorrhage because it can be a very subtle subarachnoid hemorrhage like this. But if you look very carefully, then on the right side, the sylvian fissa is not seen, and a little bit of whitish thing is seen here. But then on the left side, it's normal. So you have to have a very high degree of suspicion and look very carefully in these pictures in order to get good diagnosis. And here it's now pretty obvious, more hemorrhage, mainly on the right sylvian area, but also in the basal cisterns and interhemispheric cistern and sylvian fissa on both sides. Again, another subarachnoid hemorrhage. Now it's more dense and mainly, more on interhemispheric area, maybe anterior communicating artery bleed, but also in the, basal cistern as well as in posteriorly. So profound subarachnoid hemorrhage. And then if it's a massive subarachnoid hemorrhage with some component of intraparenchymal hemorrhage, like here, with a fluid level and a lot of hemorrhage there. And another thing that you commonly see is subdural hematoma, chronic sort of subdural hematoma. These are all chronic subdural hematoma, but this looks almost isodense to the brain parenchyma. So in order to differentiate, sometime you might have to do a contrast CT scan to see the surface of the brain where you see the vessels, and then you can see it better. But then with experience, you can say, okay, the gyri was up to here on this side, and then this much is the blood. But if you are not very sure, then you can do a contrast CT scan. But if you see a picture like this, which is a chronic subdural hematoma with a little bit of acute component here, a bilateral, more on left side, but then on right side, there is also a little bit of acute bleed. And again, a unilateral, very large, acute on chronic subdural hematoma, because there's a acute bleed as well, and a chronic blood is there. Lot of midline shift. The septum pellucidum has moved way out. You should measure it from the midline, how much of millimeter it has shifted. And then you can also see that there are membranes within the chronic subdural hematoma here. Now, another stroke patients are infarction patients, and they come pretty early, within 3 hours, and you do a CT scan, you see nothing, and then you may say, okay, this CT scan looks normal. Then you might have to move on to MRI, but you should tell the patient that even if it's not seen here, if the patient has deep hemiplegia on one side, then you will say, okay, after some time you will see infarction in this patient. Like after 30 hours, you can see that there's an infarction, which was already there, but then, it is not a new thing. It was already there. The liquefaction has not occurred, so you don't see it. But now it's more clear. But after 3 days or more, then you can demarcate the territory of infarction that has occurred. And this is again our dense MCA sign. If the patient comes pretty early, then you see something like this. But there's no infarction in the parenchyma that you see. But you must tell the patient that if you do in later CT scan, you'll see that there is black area there. And the same thing here on this side, on right side. So dense MCA side, if you follow the patient after some time, then you can see that the liquefaction has occurred, and then you can see the black shadow, low density area. Depending on which area the infarction has occurred, you can say which artery is affected. Like in this case, the right side ACA, and this is the right side ACA bleeding, which is all the way into the motor cortex as well, and like this. So these patients will have a profound left-sided weakness, but not much of ICP, because the ICP is not there, shift is not much there. Middle cerebral artery infarction will be like this, where the middle territory of the middle cerebral artery is affected, but the basal ganglia, the thalamus are spared, and the anterior cerebral and the posterior cerebral distributions are also spared here. So this is a typical M1 segment MCA artery infarction. Other cases of middle cerebral artery infarction, where you can see a wedge-shaped, MCA territory infarction, but the thalamus is spared again. And on right side, you can see there the posterior cerebral is intact, the anterior cerebral is intact. Now, sorry, this should be a PC artery infarction. The occipital lobe is infarcted here. So this is a isolated posterior cerebral artery infarction in this case. And sometimes you see something like this when they have herniation of the brain and stretching of the posterior cerebral artery. Now, this is a very, very massive IC infarction where the hemisphere, almost whole of the hemisphere, ACA, MCA is infarcted, but PCA is spared. So there is a little bit of, the sparing there. Here, the MCA is infarcted and also the PCA is infarcted. So maybe these are, in a case like this, there's a lot of embolization that has occurred into a major brain, arterial territory, and you see something like this. Another terminology that we commonly use is called watershed infarction. Like in this case, there is an infarction here, which is the boundary between anterior cerebral and middle cerebral artery. So this is, this is far from ACA, this is far from MCA. So whenever the blood pressure goes down, there's an ischemic event, then this is the place where they have infarction. And the same thing here, this is PCA, MCA territory watershed infarction. Again, this one has got ACA, MCA watershed, as well as MCA, PCA watershed infarction. And most of the time, the watershed infarction, there's some structural narrowing of the vessels, and you need to do angiography to identify. And these patients are, many times, they are surgically treatable patients and should not be ignored. Lacunar infarctions, most of the time we see it in the MRI. We don't, depend on CT scan, but on CT scan, it will look like this, or, low density area spots. Most of the time, they don't come with these presentation, but when you do a CT scan for different regions, other regions, or other problems, then you detect these things. And now, going back to other vascular problems, you can see, empty delta sign or target sign, where If you give a contrast enhance in a patient and see that there is, low density area within the sinus, whether it's a subarachnoidal sinus, transverse sinus, then, like this, then the sinus wall is enhanced, but the center of the sinus is not enhanced, means there's a thrombus there. So this suggests that there is a sinus thrombosis. Same thing when the transverse sinus is thrombosed. This is the thrombosed artery looks white, like dense artery sign that I just showed. So here you can see that the transverse sinus is thrombosed, and there is some changes in the temporal lobe, which is called a venous infarction there, because the venous drainage is not proper. There's a local increase in the ICP, and then there's an infarction there. But the whole of the brain looks still silent. And if it goes further, then you can have a venous infarction where you see a lot of shift here. The septum pellucidum has shifted almost 110 millimeter or more, and then there are infarctions with even bleeding within the infarcted area. So this is pretty serious problem on venous infarction. If you see something like a lot of ICP is there. Now, whenever there is some penetration of the dura, then you can have air inside the brain. And this is if there's a pneumocephalus or air inside the brain, then the chance of infection is there, and other problems can also happen. So some parenchymal, some subarachnoid space hemorrhages is there, but most of the time this pneumocephalus is on the surface of the brain like this. It's called a Mount Fuji sign, where there's a lot of air in the brain and which is compressing the brain and creating a lot of intracranial pressure, rising intracranial pressure. Another common presentation that you see in CT scan is a hydrocephalus, where it can be a this is a lateral ventricle is enlarged here, but not much of periventricular lucency. Periventricular lucency means the low density area that is kept in the lateral horn, anterior part of the lateral horn of the ventricles. Then this means that there's a transependymal seepage of CSF into the parenchyma, so there's a lot of pressure there. So this says that there's a lot of pressure, but this looks, almost like a compensated hydrocephalus. There's not much of pressure here. So if the patient do not complain of much problem, then just for radiological sake, you don't need to treat these patients. But these patients will have a lot of ICP and they need treatment. Another case of hydrocephalus, where you can see this patient was treated for some temporal lobectomy was done, but then there's a lot of periventricular lucency all over the brain, so there's a lot of hydrocephalus, a lot of pressure there, like this. So also in the occipital horn and the trigonal area, you see periventricular lucency like this. Now, coming to some of the common brain tumors that you can identify by a CT scan. These are all enhanced CT scan of meningioma. There's a many homogeneously enhancing mass, which is attached on the fox here. And then a little bit of dural tail is there. Dural tail is a part of the tumor. And on the convexity again, so these are actually extraaxial tumors. This is not actually, technically speaking, it's not inside the brain, it's outside the brain, And again, a little bit of cystic component with a meningioma on the convexity there. And this is a trigonal meningioma coming from the choroid plexus, the capsule of choroid plexus, and then you can see a lot of edema around it and a lot of shift. Again, some other cases of meningioma here, the bone has been eroded here, and the tumor is in the anterior temporal lobe of right side and has invaded into the orbit, and then it has pushed the orbital wall, the orbit itself anteriorly. So there's an exophthalmos, the eyeball on this side is relatively popping out So the only thing that you may notice in a patient like this when they come to your clinic is you see a unilateral proptosis only, and they may not even have any visual problems. But if you do a CT scan, then you can see a very, very big tumor like this. Now, again, this is image of an MRI, but I just want to show you that sometime in a cerebral pontine angle, also you can see a meningioma like this, and the meningioma will have a broader base, so you need to differentiate between Aucostic Neurinoma, which will have intra-auditory extension into the internal auditory meatus, like a cone shape there, but in meningioma you don't see like that. Now, coming to high-grade tumors, plain and enhanced on the same patient, there is a lot of edema there. There's a mass effect, effacement of the ventricle on one side. And if you do a contrast, the wall, the periphery of the wall, ring enhancing sort of enhancement, there's a liquefaction in the center of the tumor, and these are edema. So if you see a picture like this, then most of the time these are high-grade glioma, maybe glioblastoma multiformis grade 4, but it can be something else as well. So for a definitive diagnosis, you need to do a biopsy for these patients. Again, high-grade glioma with a little bit of almost like a, budding. It's not a satellite lesion. Satellite lesions are actually not attached with the main lesions, but it's like a budding of a tumor. So if you see something like this, then these are actually a very, very high-grade glioma, because they are rapidly enlarging on one side. And if you see satellite lesions, which is separate from the tumor itself, then these are, again, very high-grade gliomas. These are butterfly lesions, again, part of high-grade glioma, where it has invaded into the corpus callosum, into the ventricular system, and on both sides. And so these are, again, a very, very nasty tumors. This is on the genu, and this is on the splenium, on the posterior aspect. Again, same butterfly lesions. This is a plain and enhanced, contrast enhanced medulloblastoma. Here, what you can see is it's almost an isodense, or maybe a little bit of hyperdense, and there's a rim of low density area around the mass. And then there is a trigonal, triventricular hydrocephalus, where you can see the lateral ventricles are large. Again, the periventricular lucency is there. The third ventricular is large. The temporal horn is big. If you do a contrast, this is another, same case on the basal aspect, then you can see some contrast involvement and a lot of mass effect there. So these are medulloblastoma. And again, on posterior foci, you can see a small, enhancing lesion with a big cyst, which is most likely a hemangioblastoma, and which can be very small. We also call a mural nodule, a nodule there, and a big cyst, and brightly enhancing, but the cyst wall is not enhancing in these cases. And another is a pilocytic astrocytoma, where the enhancement effect is not very high, and you see a large cyst, and again the triventricular hydrocephalus, the temporal horn, the lateral ventricle, and the third ventricle are enlarged. Another case, similar picture. This is a plain CT scan where you see there's a mass there with a calcification. Another case with a lot of calcification and a cystic, irregularly dense, So these are oligodendrogliomas, mainly seen in frontal and also in temporal lobes. And this, again, is a calcification in sellar parasellar area, which is a craniopharyngioma, and these are calcification and cyst there. Again, calcification, and this one do not have a cyst. So craniopharyngioma can be purely cystic. It can be mixed like this, cystic and solid, or a solid like this, where there is no cystic component. Now, another tumor that we come across is a pituitary tumor. CT scan is not a very good technique for identifying, paracellular or cellular lesions like Pharyngioma, pituitary tumors. But if it has got a bigger tumor like this, and if you do a reconstruction of an axial, coronal, and sagittal images, then you can very clearly see the pituitary tumors. And CT scan is sometimes important in pituitary surgery to identify where if there's a septum within the sella, and then you can identify and then plan your approach accordingly. Another tumor that we commonly come across is Aucostic Neurinoma, unilateral sensory neural hearing loss, and you see something like this on CT scan. Then it is most likely Aucostic Neurinoma. And this is the internal artery meatus in which the tumor is going. But again, I have told in my previous class that, the posterior fossa is not a good place for CT scan. So you can miss Aucostic Neurinoma very, very commonly. And you also should ask for a bone window in Aucostic Neurinoma to see the widening of the internal artery meatus like this, so that that even though you don't see a parenchymal mass very clearly there, but you can suspect by this picture. Here there is bilateral Aucostic Neurinoma that you see in the CT scan, which is due to neurofibromatosis 2, type 2. And again, I emphasize that these are not very good for posterior fossa or cellular and paracellular lesion CT scan. Here you can see that the ear cell, the mastoid ear cell, has come all the way lateral to the sigmoid sinus, medial to the sigmoid sinus. So, in order to approach this lesion, you will know in advance that you have to drill the ear cell as well. Unless you do that, then your corridor is not good enough. The name suggests that the tumor is in the center of the brain, and most of the time it is, the attachment is in the thalamus or lateral ventricle area. There's some calcification there, irregular looking tumor. Some enhancement is there. The ventricular asymmetry, many times you see the septum pellucidum has shifted to here, this side. So the one side ventricle is big. And so this is central neurocytoma, which looks like this. And besides high-grade glioma, you see low-grade glioma like this. And they will have some mass effect there, not much, but almost no contrast enhancement, or maybe a little bit of contrast enhancement. And these are the tumor which most of the time need to be removed. But if you want to observe this, then you can serially, take CT scans and then, decide accordingly. Now, some of the parasitic cysts that you see, here, you see that it looks almost normal. There's something there, but a little bit of edema. Otherwise, looks pretty normal. But when you do an enhanced scan, then you see that there's a ring enhancing lesion with a dot in the center. So this is a classical picture of a neurocystic sarcosis. And this cyst is already dying. It's a solitary single cyst, and the chemical has gone out, so there's an edema around it. And these are the time when they present with seizure and come to you for a treatment. And you see something like this. And this is another type of neurocystic sarcosis, mainly seen in South American region. Solitary lesion, this is seen in India and Indian subcontinent area. Why there's such a difference, nobody knows. The genetic is same, nobody knows. But then this is multiple, stage 1. So these are living cysts, punched out living cysts like this. Looks like a Swiss cheese. Not a good name for a nice food. And then you can see so many multiple, cysts with enhancement, and some are active. So this is active. There's edema around it. This is active edema. Active means, in my experience, these cysts are dying. So they release their chemicals outside, and then there's an edema. So that's the time when they have, neurological deficit or seizure. But they can present with just a calcification like this, on a scar like this. If you see something like this from an endemic area, the patient have no problems, then you just leave it behind. But sometimes they reactivate and there's an edema around it. And this is the time they have seizure, and you need to treat the seizure at that time. So again, this is the cyst has reactivated, and you can see, although this is a calcified dead cyst, but there is a edema around it, which means that because of some mechanism, the cyst has been reactivated. Well, coming to almost the end of my slides, you can see calcification like this in the inner wall of the ventricle, and also in the parenchyma, maybe something like this, which is seen in tuberous sclerosis. And if you look at the patient, then you'll have tuberous sclerosis patches in his cheek area and nose area as well. So now coming to some of the infective lesions that you can see, there is in this enhanced CT scan, you can see that if it is a plain CT scan, then you may say, oh, this is a subarachnoid hemorrhage, but this is a enhanced CT scan where you can see again, a hydrocephalus there. The temporal horn is pretty big. It should not be visualized or less than 2 millimeters in adult. So this is pretty big. And then you can see a loss of enhancement in the basal cistern. Here again, the same thing here. And again, the basal enhancement. So the tubercular lesion has sunk down into the base of the skull and has caused a lot of massive basal arachnoiditis. And there's a solitary tubercular cyst here with the edema around it, and also the ventricle hydrocephalus, profound hydrocephalus is there. Beside tuberculosis, you can have a bacterial or a fungal infection, which will look like this. Here, these people will have an acute pus collection in the brain, so the symptomatology is pretty acute, and they come with a very, very severe ICP. And if you do an enhanced scan, then you see something like this. Again, a brain abscess there. So this is my, I think, the last slide, where this is a Hydatid cyst, which the cyst is, isodense to CSF, and it has got a very thick wall. So there is no spillover of the cystic content into the brain. So there is no edema. And there's a potential cleavage. This is actually extraaxial. So most of the time, if you do a fine dissection, you can just remove this in total. So with this, I conclude my presentation. And to understand this presentation, you need to go and look at my previous presentation, how to read a normal CT scan. And subsequently, I will be talking about how to read a normal MRI and then a pathological MRI. Thank you very much for your attention. Thank you.